Hello and welcome to the 2018 ICD-10-PCS Code Changes brought to you by Healthcare Resource Group. Did you know that if all letters and numbers were used in the medical surgical section of ICD-10-PCS minus I and O, you would have over 1.5 billion possible PCS codes. That's 2,000 times the current number of codes. And if you lined up your handy PCS books one at a time, one for each code in it, it would reach over to the moon. There's 1.26 billion feet to the moon by contrast. But don't worry, I don't think we're going to get there quite in our lifetime. My name is Ed O'Byrne. I'm the Director of HIM Revenue Integrity for Healthcare Resource Group, and I've been a clinician as well as a coder for almost a decade, and quite enjoy PCS in particular in my coding roles. So for 2018, we have 3,562 new codes. And remember, a new PCS code is born with the simple addition of one of the characters in a PCS code. For example, an addition of one device can generate potentially 100 new codes too. So don't be daunted by the raw number of actual new codes in 2018. But for those who like to focus on these kind of random statistics, 1,821 will be revised. Not an insubstantial number will be deleted for some interesting reasons, which you'll see. So what we end up with in 2018 from 2017 is 75,789 up to 78,705. So in case you care to dig into the statistics even a little bit more, we'll see the transition from 2017 over to 2018. And in 2018, what sections are comprised of how many codes. No surprise, medical and surgical is by far the lion's share of PCS. And we'll spend most of the time in this presentation looking at the medical surgical section. There's a tiny bit of obstetrics. We'll look at a little bit of administration and some new technology. And honestly, we'll cover, or at least touch on, probably 90% of the code changes, either as a specific instance or as a sort of a thematic change within ICD-10, where there's sort of one shift in the philosophy of PCS that affects lots and lots of codes. So now don't be frightened, because remember, the PCS manual has lots of empty space too. The way it's designed, it's not enumerated code by code by code. So it's quite possible to add many different approaches on most pages, many different devices and qualifiers. And in fact, I just measured my 2018 PCS book by the same publisher compared to 2017, and it was 2.5 millimeters thicker, but I confess is a slightly different edition, and it does have some coding clinic references and so forth in it. So I think in the end, most of us will live to see the day where the PCS code maybe grows just a teensy little amount, not much worse. So let's look at the front of the book first, the ever important PCS guidelines. I love the PCS guidelines because they only occupy about 3 pages, and they really truly do cover most of what we need to know. Naturally, there will be coding clinics involved, but the PCS guidelines are much more concise than CM. And there are 3 that were revised. So let's look at the first revised PCS guideline code. It's the Discontinued Procedure Guideline B 3.3. And this is really just a little wordsmithing change from discontinued to discontinued or incomplete. So this just broadens the circumstances as to why the intended procedure didn't fully go through, whether the surgeon or the team intentionally discontinued it, as in the 2017 nomenclature, or just somehow didn't quite get there enough for you to code it in PCS. So discontinued or incomplete, i.e. otherwise not completed, then code the procedure to the root operation performed up to that point. If no root operation was met in the discontinued or incomplete procedure, of course, we've got inspection to fall back on as our root operation. This is one I'm pretty excited over, partly because it just caused a lot of confusion in educating coders due to a kind of a grammatical glitch, I think. So 2017, I was pleased to see, I think a lot of us were, that the control root operation was expanded from just post-procedural bleeding to or other acute bleeding, which makes a lot of sense, doesn't it, after all? But then what was added was, and to stop the bleeding requires performing any of the definitive root operations: bypass, detachment, excision, extraction, reposition, replacement, or resection. And worded that way, it's as if only those root operations take precedence over the root operation control. What's been done in 2018 is deleted any of the definitive root operations and replaced with what makes a lot more sense, a more definitive root operation such as, and then it enumerates some common root operations that would be used for control of bleeding. However, it doesn't exclude any other root operation as long as it's more definitive root operation than control too. So by all means, I would encourage you to focus on really if what was done comprises a specific root operation and pick that one first before control. So in some ways, this should reduce the use of control, whereas with the previous tweak from 2016 to 17, it kind of increased as it included the acute bleeding. Here's kind of an interesting one, and I can only sense that this came from a real-life scenario of coder confusion. It has to do with tubular body parts with contiguous root operations along that tubular body part. So the guideline now goes, if a procedure is performed on a continuous section of a tubular body part, we code the body part value that is the furthest anatomical site from the point of entry. It's interesting. So I've chosen, in this case, an iliac, femoral, popliteal, and subsequent to that, artery here, shown on angiogram. And let's imagine the insertion site was the femoral artery right here. And the entire thing was dilated proximal and distal from that point. So governed by this guideline, we would code to the furthest point from insertion, so from the femoral down to potentially the peroneal or posterior tibial, both branches of the popliteal, would be the one code in PCS that we would need. It's a little strange, I admit, but there is the guideline saying just use the furthest anatomical site from the point of entry for, again, a continuous section and for one root operation. Another PCS guideline tweak has to do with device guidelines, and this is a very unique instance, not super common, but it's important to note, and it departs greatly from what we as coders conceive of as a device, wherein that device is coded only if a device remains in after the procedure is completed. And we've got that all beaten into our heads. Now we've got an exception to that adds qualifier values, 7th character qualifier, temporary and intraoperative, because there are special instances when a device is inserted but only during the procedure that it's done, or somewhat slightly afterwards, but it's intended to be removed. However, it's substantial enough to be coded as it qualifies that variety of the procedure from perhaps other less invasive or less advanced versions of the procedure. So I'll just let you read it in bold here, the addition to the PCS guideline B6.1a about devices. An example of that temporary device guideline is what we see here, an occlusion of the thoracic aorta descending with an intraluminal device, temporary qualifier, percutaneous approach, or of the abdominal aorta. So you wonder, why would you occlude either thoracic or abdominal aorta with an intraluminal device temporarily? Well, one example of this would be a patient who's suffering some severe hemorrhage from, let's say, a leg wound, and in this exact example, it would be in wartime from combat trauma, severe leg trauma with an extensive amount of bleeding. The first line of defense may be to occlude the abdominal aorta with an intraluminal device to actually sort of tourniquet off the entire arterial blood supply to the lower body so that hemorrhage stops, then until the surgeon can go in and control the damage directly, and then provide a definitive treatment for that for the trauma and the hemorrhage, and then remove the occlusive device. A ruptured AAA might be in the real world for us civilians more likely to encounter. A ruptured AAA might be occluded off. Also, intraoperative and temporary cardiac assist devices falls in this category too, and the qualifier is right there. It says intraoperative or temporary. It's very easy to find. As for what you can expect for the individual PCS characters changes, I'll go over a couple of these. Some of them are universal enough that I will treat them as thematic changes, which is to say they apply to so many body systems, root operations, and so forth. It's worth discussing them as one big overarching concept, and then we'll delve in a little bit more to the body system specific or really like detailed device specific changes. Nonetheless, in the body systems, there's no changes. No body systems were added. I kind of don't expect there ever to be. Root operations were added to certain body systems, not new root operations, but just an application of an existing root operation in a new concept to a body system. Certain body parts were deleted or reconfigured or combined, as you'll see in some ways, perhaps to just economize in the space and the sort of conceptual energy we spend in thinking about body parts, and also to rescue us from some interesting documentation deficiencies. Approaches were added and redefined for certain body systems. As with every year, we're going to see devices added and qualifiers added. That's just what that character was made for, that seventh character qualifier, to be added onto and added onto. The first big thematic change is, I say new device, but it's really nothing new about it. It's simply the addition of the term other device to the device character in many, many ICD-10-PCS codes. And I can only think this was the committee's attempt to, at the same time, kind of throw up their hands and realize that they can't possibly cover all the new devices year by year by year, but also to give us kind of an out. It's almost, in a sense, not otherwise specified, which I cringe a little bit in PCS to think about, but gosh, things are evolving so fast in medicine, sometimes we just need an other device. And this occurs in many body systems, parts, and root operations. And here's just one of hundreds of examples. Insertion of other device into upper vein open approach, for example. All we have now within that category code is infusion device, intraluminal device, neurostimulator, neurostimulator device, and a couple of others, but nothing like other. For example, this is a RVAD, radio frequency ID chip. This one is actually for a pet, but imagine one of these days we have these installed in ourselves, and that gets invented mid-year before PCS can create a new device character for it. Well, we've just got the other device for the time being. So watch for that to evolve, but we've got that to fall back on in many, many instances. One that's a little harder to get your head around, but I think is pretty exciting shift in the way approaches are treated in PCS. I'm going to throw you some examples and have you think about what the approach is, what you would have coded it, or what you have liked to have coded it. The first example, functional endoscopic sinus surgery, FESS, because anatomically this is not hard to understand. This is insertion of a tube and a camera into the frontal sinus, through the nose, through the sinus ostia. There's no cutting usually involved. There may be some incidental cutting around the ostia to open it up and allow passage, but that's not definitive of the procedure. So the PCS code options, we would see 099S, 0 for open, 3 for percutaneous, 4 for percutaneous endoscopic, and those are the approaches we are offered. So here you can see that scope going through the nose, through the ostia of the sinus, right into the sinus. So there's no open, there's no cutting through membrane, skin, or otherwise. And again, it's maybe endoscopic, but what's percutaneous about that? So it's a little bit of a head scratcher in 2017. Okay, come at that at a slightly different angle, no pun intended there, pertaining to transbronchial endoscopic lymph node aspiration. This is a coding clinic, and this is an instance where a bronchoscope is placed in the patient's lungs, and there is a needle punctured through the mucous membrane. So in sort of as the scope goes, it's actually an endoscopic percutaneous. The scope goes in the mouth, natural opening, and then the percutaneous part happens in the lung. Nonetheless, the coding clinic guides us to code an excision of the thoracic lymphatic percutaneous endoscopic. So many of us have come to think of this root operation as synonymous with endoscopic percutaneous. Doesn't matter if the scope goes in first and then the percutaneous part happens, or the percutaneous part happens like in a laparoscopy and then the scope goes in that percutaneous wound. So that's kind of where we're left in 2017, not having any additional guidance or root operation to choose from. So just to review the distinction in the definitions of these approaches, the percutaneous is entry by puncture or minor incision of instrumentation through the skin, mucous membrane, or any other body layers necessary to reach the site of the procedure. So this shift we see in 2018 recontextualizes the site of the procedure. So bear with me. The definition of the via natural or artificial opening, aka just endoscopic, I think of it as entry of the instrumentation through a natural or artificial external opening to reach and visualize the site of the procedure. So is the site of the procedure the actual body part that's being worked on, or is it the overlying surface tissue that must be cut open into to get to that point? When I say a new endoscopic approach, it is not a new approach character in PCS. What I mean to say is the endoscopic approach through natural or artificial opening now applies to certain structures that are in fact behind mucous membranes or other tissue that would have to be gone through to get through it, yet we're offered the endoscopic approach. So this could only signal a shift in the way that the endoscopic approach is considered that allows some incision to be made once the scope is inserted. Think about these instances for a second, and I'll discuss them. The inner ear structures like the ossicles and the cochlea, really the only practical way to get through to those is through the tympanic membrane. So it challenges us to think of puncturing the tympanic membrane. Does that become percutaneous, or will that fly as endoscopic? Well, in 2018, we're given the endoscopic approach for those structures. That would imply that puncturing the tympanic membrane still fits under endoscopic. How about the nasal septum? Well, that is definitely under mucosa and skin, yet we have the new option of endoscopic approach for the nasal septum. So placing the scope through the patient's nostril, that's a natural opening, and then working on the septum can be endoscopic. How about lymphatics? As far as I know, there are no lymphatics that are accessible in any direct way through a natural opening, so it could only imply going through a tissue or membrane. For example, a thoracic lymphatic that's accessed through a bronchoscopy, like the previous example I gave in the coding clinic. Pancreaticobiliary tract. Let's take the pancreas itself. Sure, it could be catheterized through the sphincter of Oddi, but what is, I think, really meant by this new endoscopic approach for the pancreas is a biopsy through the wall of the small intestine. And then the reproductive systems, it's a little bit more obscure, but if you kind of understand the plumbing, there's really no way to get to, for example, the testicle or the ovary directly through the tube, except through the wall of the tube. So what I mean to emphasize here is that we're being permitted to use an endoscopic approach in instances where there is some penetration or perforation of some tissue when it's done via a scope. Here's some real-life examples of 2018 PCS codes that use this sort of newly defined endoscopic approach. Excision of the right auditory ossicle, that's the bones behind your tympanic membrane, and it's via natural or artificial opening, endoscopic, i.e. through a scope put in the ear canal through the tympanic membrane and working on that ossicle. Destruction of the right frontal sinus via natural or artificial opening, endoscopic. That's like the FESS procedure in the previous slide. Occlusion of the bilateral vas deferens with extraluminal device. Now you may say, well, the scope is going in the vas deferens, therefore it is truly endoscopic without any perforation. But notice this, there's an extraluminal device. What this code anticipates is placement of a urethroskop that then goes through the wall of the urethra, visualizes the vas deferens, and then occludes them with an extraluminal device like a clip. Or probably of all of these, the most common we would encounter as coders is drainage of a thoracic lymphatic by natural or artificial opening, endoscopic. And that's your classic bronchoscopy with a transbronchial lymphatic biopsy. So just to look at this with a picture, the middle ear structures and many root operations by this approach, excision, replacement, repair, etc. Let's take an excision of a left auditory ossicle via natural or artificial opening, endoscopic. The only approach we're offered in that now is open, which would imply that any incision made in the skin or the tympanic membrane automatically makes it open. There's not even a percutaneous or percutaneous endoscopic. So the scope would go in the external auditory meatus through the tympanic membrane, and I'll go to the zoom, through this tympanic membrane, an excision of one of these ossicles through that. Now we can do that with an endoscopic through a natural opening. So where this may all be leading is what's termed N.O.T.E.S, or natural orifice transluminal endoscopic surgery. Now the examples I gave before are sort of pre-existing examples of this, but as it really fully evolves, we may be doing more and more procedures through a natural orifice and through the wall of that orifice. What we see here in the illustration is a trocar placed through the vaginal fornix, so that's up at the upper extent of the vagina and perforated through. Here's the uterus right here. Now in this example, in order to get a picture of that trocar, naturally they had to put in a laparoscope, which itself would be percutaneous endoscopic. But through this trocar, hypothetically, any procedure like an ovarian resection or a uterine fibroid resection or even an appendectomy or a cholecystectomy may be done through that trocar, and that's what's termed N.O.T.E.S. So unless a new root operation is created, which I think would be really cool, we have the through natural or artificial opening root operation for whatever's done through that trocar right there, no longer needing the percutaneous endoscopic. Now these N.O.T.E.S procedures involve some really interesting instruments like this laparoscope that's got the camera right here. It's got an aspiration and irrigation probe right there, which is extensible. It's got forceps. It's got a little cautery probe. I can't help but think these look like the sentinels in the Matrix, in the movie The Matrix. I mean, come on, look at that thing. And who knows what they'll come up with next. Now getting into some of the more specific examples that are not quite as broadly thematic as before, and I'll do this sort of by the relevant body system or by the relevant root operation. In this instance, we're looking at this central nervous system and the peripheral nervous system. We have a root operation addition, and that is replacement. And heck, that's not an uncommon thing done. I'm surprised that it wasn't integrated in the first place. But what we have in the central nervous system, we have all kinds of replacements of dura and central nervous system parts, including cranial nerves. And in this case, we see a median nerve replaced by some autologous substitute. It's been lacerated here, or crushed, let's just imagine, in between. And a sural, S-U-R-A-L, nerve from the leg has been taken out and grafted in between. It's just an ordinary graft, just like many tissues are grafted. This one just happens to be a nerve. So we have now replacement of here's my example of a peripheral nervous system replacement of the median nerve with autologous tissue substitute taken from the patient's own body, open approach. What we might have used in 2017 and before could only be supplement, which requires a little bit of mental gymnastics to imagine that you're sort of supplementing the existing nerve rather than replacing the nerve itself. A new root operation in respiratory, similar to the nervous system, replacement as well. So in the respiratory system, we have all sorts of body parts: the trachea, the carina, which is the fork between the two main stem bronchi, the bronchi themselves, and even the diaphragm. And this is harder to conceptualize than the previous example of the nervous system, but not impossible to, for example, replace the part of the trachea through a percutaneous endoscopic approach with a synthetic substitute, maybe like a plastic trachea. But now we know that we have replacement for the respiratory system, so keep an eye out for that. In the nervous system, we have a few odds and ends to do with the root operation supplement. Going back to that, the CNS just adds body parts. The cerebral ventricle in particular, there were already some supplements in this central nervous system. We just added body parts. In the peripheral nervous system, we had supplement to choose from, but we added some devices, and essentially that was non-autologous tissue substitute. So allograft or cadaver graft for certain things like supplementing the facial nerve, and that might be a nerve conduit that's derived from a cadaver that was applied around a facial nerve to promote it healing when otherwise no other root operation was done. We have a clarification of a body part in the central nervous system, and that's the epidural space. So it was simply said epidural space, and now the definition of that is intracranial epidural space. Now in the alternative terms in the PCS tabular, it actually said intracranial, and to distinguish it, the spinal canal said epidural space spinal. So this is really just a teeny little wordsmith thing to say intracranial. So you don't accidentally see epidural space and accidentally gravitate to either the intracranial or the spinal canal epidural space. It just kind of clearly defines the two apart from one another. So an example of a code would be drainage of an intracranial epidural space with a drainage device percutaneous. For example, this epidural hematoma, which you can tell on CT scan because it is tethered, as the dura is tethered here and over here inside the skull. So the epidural hematoma collects and causes a very high pressure locus right here against the brain. Conversely, a subdural hematoma occurs under the dura and can spread out much more diffusely around the hemisphere of the brain. That's why epidural hematomas like this are much more dangerous, and an emergent procedure like a drainage of it, you see here of that epidural space, is necessary. Now under CNS extirpation, we have a clarification of some body parts and addition of a body part. Under the epidural, subdural, and subarachnoid, these are now termed intracranial. It was actually already in the alternative term descriptor there. It just required a little additional attention to that. But what we add is the body part spinal canal for extirpation. For example, this code for extirpation of matter from the spinal canal open approach. Like you could imagine there being a clotted solid hematoma somewhere in the spinal canal from blunt injury that requires a removal of that clot. And here is the code you would use. Now, be careful to distinguish. There was and still is the spinal cord designated by cervical, thoracic, and lumbar as a region. That's another body part, so take care to note that if that hematoma is inside the spinal cord versus in the epidural space, and whether that epidural space is intracranial in the head or in the spinal canal. It makes all the difference in your code choice. In the CNS body system, we have an application of the new approach, and that's percutaneous endoscopic. Not hard to imagine adding a scope for CNS procedures, and this is not an uncommon one here, of insertion of a ventricular peritoneal shunt through a scope. Many root operations occur, but drainage and bypass are going to be your top ones that you're likely to encounter. For example, the bypass cerebral ventricle to the peritoneal space. That is a VP shunt. And here's an example in cross-section of that scope being placed through the fissure between the hemispheres of the brain into the lateral ventricle, into the third ventricle. In this instance, it looks like it's sneaking in there, and placement of a catheter down through the foramen there, and then down the spinal canal where it's tunneled out into the peritoneum. But nonetheless, we can clearly see we're looking inside that ventricle for placement of the device. So that could only be percutaneous endoscopic. The hard and great vessels bypass. Boy, there are a lot of new flavors of bypasses to and from. And I won't go into too great a detail except to say from the outset of this, we're simply given many more choices of things to bypass to and from, and it just requires diligence as you code these to carefully understand the body parts and what's going on as they replumb these bypasses so that you pick the right PCS code. We remember in 2017 the aorta was split to the ascending and descending, so that's one more element of anatomy for us to understand. And then for 2018 we were adding bypass to axillary and brachial arteries too. Currently we're only given a aorta bypass to the subclavian, the carotid, and the pulmonaries. And this may be to bypass a coarctation or some other stenosis in the aorta itself or in one of these vessels too, requiring, for example, a synthetic bypass graft to bring oxygenated blood from the aorta past the obstruction into the subclavian, carotid, or pulmonary arteries. Now we've got the axillary and brachial arteries. So it just added what is really just branches of the subclavian. Now they have their own specific body part values. In the hard and great vessels, we've got a slight little tweak of the terminology for the BIVAD, so this biventricular assist device. There's also a left ventricular assist device and a right ventricular assist device, and the BIVAD is simply a combination of those two. This pertains to, like all devices, insertion, revision, and removal. Essentially, those always travel as a trio, and the device is the external heart assist system. So what happened to this is the qualifier addition of a short-term external heart assist system into the heart, always done by open approach. Sorry, the qualifier is biventricular, but the device term is short-term. Now, the external heart assist systems so far are essentially all short-term bridges to transplant. There are internal ventricular assist devices and even artificial hearts altogether, which are not meant to be short-term. They may be palliative, so the patient can actually live somewhat longer. So it's important to read the context of the insertion of the BIVAD to determine if it's short-term. It's just meant to hold the patient over until they can get a heart transplant or other definitive treatment. Here's what a BIVAD looks like in real life and in a diagram. And BIVAD is simply a combination of a left ventricular assist device, left ventricular and right ventricular assist device too. Here you can see this somewhat pinker, more oxygenated blood in the left heart, and there is a little diaphragm in here that sort of pumps in and out by this pressurized fluid or air here that causes the blood to come, in this case, out of the left ventricle here through the apex, through the pump and back into the aorta, and then out to the patient's body. The right ventricular assist device brings blood from the right ventricle and pumps it through the pump and then into the pulmonary arteries on its way to the lungs to be oxygenated. So that's why you see this deoxygenated right heart blood here, kind of purple, and the oxygenated left heart blood going through the pumps there. For heart valve replacement, we have the addition of the replace root operation via percutaneous approach of the tricuspid valve, including a transapical. So it can be percutaneous endoscopic with a 7th character qualifier of transapical, meaning through the tip of the heart through a minimally invasive incision down below the rib cage too. Essentially, this just adds the tricuspid valve to the existing choice of percutaneous and transapical to aortic, mitral, and pulmonary valves. So we've got all 4 valves replacement essentially by any route. So that's just a little bit of PCS housekeeping. We have the addition of an occlusion of the pulmonary trunk or right pulmonary artery, and this essentially adds to the existing scenario of occlusion of the left pulmonary artery with the qualifier of the ductus arteriosus. So in most cases, there's really only one branch of the pulmonary artery one would want to occlude, and that's a ductus arteriosus. And for example, a baby whose patent ductus arteriosus was causing a shunt and therefore problems, and it needed to be closed up. I suppose this occlusion of the pulmonary trunk or right pulmonary artery may account for anomalous origins of the ductus arteriosus or some special weird scenarios where they really truly need to occlude the pulmonary trunk. But nonetheless, we are now given that option. Other odds and ends in the heart and great vessels, miscellaneous, dilation of the left ventricle by many approaches, and release of coronary artery as a new root operation for coronary arteries in case a coronary artery was constrained by some abnormal physical constraint or tension. Now we have a release. Still in the vascular system, but moving into the arteries too, we have within the qualifier bypass 2, of course, we have many different peripheral arteries to the superior vena cava, which is a vein, of course, but since we're bypassing from an artery, that's the body system you'll find it in. It just so happens that the qualifier will be the superior vena cava. In 2017, really all we had was the arm and leg vein, and now we have the superior vena cava. We also have bypass of the carotids to some other extracranial artery. Also adds right to left and left to right, whereas previously it was just ipsilateral, so right to right and left to left, in case you encounter one of those special instances. And then this is a case where it's just too numerous to enumerate. The lower arteries bypassing to other lower arteries and other visceral arteries. You will never run out of options in that instance when you're doing a replumbing job of those arteries. Why might one want to bypass a peripheral artery like the brachial or axillary artery to the superior vena cava? Well, most of us are familiar with the idea of an AV shunt for hemodialysis, which may take brachial artery arterial blood and shunt it right into the adjacent, say, brachial vein, which returns eventually back to the superior vena cava. And what that does is provides a nice brisk flow by the hemodialysis system, which are a pair of needles inserted just distal and proximal to one another in the shunt so that it can pump blood out, filter it through hemodialysis, and pump it right back into the patient's body. The problem with that is the arterial and/or venous tissue or even a short synthetic graft is only tolerant of being punctured but so many times before it can become clotted or stenotic or tortuous or otherwise diseased in such a way that that AV shunt needs to be replaced, unfortunately. Here we have the HERO device, or hemodialysis reliable outflow device, which takes advantage of that new bypass 2 seventh character qualifier of the superior vena cava now in 2018. Here's an example of what that code would look like. And clinically, what that means is the blood is tapped off of the brachial, or we have the axillary artery body part to choose from as the origin of the bypass, through this Teflon tube or graft, which is quite long and very tolerant of being punctured many, many times with the hemodialysis needles, and then an open semi-rigid catheter which carries the blood right into the superior vena cava. So that's not likely to stricture or occlude in any way, hence the reliable outflow part. It doesn't rely on any native peripheral veins to return the blood to the central circulation. So the HERO device would be coded as such in the picture that you see here on the right. Bypass right brachial artery to the superior vena cava with that synthetic Teflon and plastic substitute, done by open approach. A little bit more arcane change in PCS, which might be utilized by some of us in very specialized surgical centers, is the bypass of the hepatic artery to the renal artery. So not hard to imagine the renal arteries can become stenotic or atherosclerotic in such a way that it occludes blood supply to the ever important kidneys, which do the filtering of our blood, or the congenital conditions can cause this as well. Now, there are a lot more convenient arteries to bypass to the renal artery in this area, like the celiac or the splenic artery or the iliac artery or the aorta itself. But what happens when the patient may have had an abdominal aortic aneurysm and has been surgically treated with a graft, which may, in this case, covers the lower aorta and down to the iliac arteries, but if anybody who's coded these know that these grafts can extend way, way up around the visceral arteries, up under the diaphragm here, and potentially way down towards the femoral arteries too. And these cannot easily be tapped into for a bypass graft themselves unless they come from the vendor that way, and some of them do. But if this is an afterthought bypass to the renal artery, you've got no place to tap from. Well, now we're just given this other choice, the hepatic artery, which is kind of way, way higher up over here, to bypass down into the renal artery if you need it. So now we have that code, and it joins the aorta, splenic artery, and the iliac artery as the source for the bypass to the hepatic artery. Speaking of vascular things, we have a device name change, which just sort of formalizes what has really already existed, but it really kind of clearly draws the line too. So we revise the vascular access device to the tunneled vascular access device, and that distinguishes it from like a Groshon catheter or a central line that's not tunneled, that's not fully implantable too. So it just kind of clarifies it. So you see a tunneled VAD, you know what you're dealing with too. Also, the reservoir concept simply changed it from reservoir to say totally implantable vascular access device. That means nothing sticking out of the patient's chest. It's just that little reservoir just beneath the subcutaneous tissue, usually in the upper chest as it is. So that's pretty slam dunk. Little change in the terminology there. Something I haven't yet encountered in my coding real world is a new qualifier of the dilation with drug-coated balloon. Important to note, it's not a drug-coated stent, which does exist in certain body systems and certain device qualifiers, but this is the drug-coated balloon. I can only assume that this has some anticoagulant or some sort of anti-inflammatory in it. When the dilation occurs, it provides some benefit. But here's an example of that dilation of the celiac artery with an intraluminal device. That's the stent, and that may or may not be drug-coated, but this is the drug-coated balloon. So keep an eye out for that. To clarify the body part nose, a few little adjustments have been made in the terminology that the nose body part becomes nasal mucosa and soft tissue. And this would be to distinguish it from the skin of the face outside the nose body part, nasal mucosa and soft tissue, and the nasal bones, which are respectively in totally different body systems themselves. You've got the integumentary, and then you've got the bones, the upper bones, the cranial bones. This applies to many root operations, and one example may be alteration of the nasal mucosa and soft tissue with an autologous tissue substitute. So this code may derive from harvesting, for example, some cartilage from the patient's ear and giving them a nose job by changing the soft tissue of the nose to reshape it, and that's what an alteration is. A bit more arcane, but an addition of an approach to an existing root operation for the respiratory tract. We add endoscopic and a supplement of such body parts as the trachea, the carina, bronchus, and lung. Similar to the replacement mentioned earlier too. All we've had to choose from now is open, percutaneous, endoscopic. For that approach to supplement of those pulmonary body parts, now we have endoscopic. So that may require, as we discussed earlier, some cutting, but it's fundamentally done through a scope, therefore makes the approach endoscopic in this case. For GI reposition, we add a body part, or essentially add a not otherwise specified, let's just say. That may sound kind of freaky on the surface of GI reposition, but actually hernia reduction is simply a reposition of a GI part. But how often have you ever seen somebody reduce a hernia and they specified it as ilium or jejunum or transverse colon or something like that? Because you can't really tell. So what we've done in 2018 is simply added two new not otherwise specified type body parts, large intestine and small intestine, through a variety of approaches too. So in the case of external or percutaneous, that's the instance where you'd see it used in the context of a not otherwise specified, because the surgeon can't really see what they're working with. Now, if there wasn't actually an open approach and they just simply didn't say which part of the intestine they were working on, or endoscopic, when they probably know which segment of the intestine they're working with, but they don't specify it, we've got a backup plan, and that's large intestine and small intestine reposition for our body parts too. So an example of a reposition large intestine via natural or artificial opening could be a replacement of an intestinal procedentia, which would be a prolapse of the rectum, and at least to truly use this code, it would have to be some part of the large intestine, like the sigmoid, which prolapses out through the anus. And if that is replaced back up through the anus, repositioning it to reduce that prolapse, here would be your code. There were lots of extraction root operations added to many different body parts, some of which make sense to me, some of which don't as much, but obviously it occurs. Let's review the definition of the extraction as pulling or stripping out by use of force, not cutting. Okay. In some cases, this makes sense. I'm quite familiar with harvest of tendon and muscle, less so by bone, but bone marrow by extraction. Here below we see a tendon stripper, which is actually right in the definition of extraction, and a common place to gain tendons for reconstructing the anterior cruciate ligament in the knee is the hamstring tendons in the back of the thigh. So a small incision is made over one of those tendons, and these tendon strippers, which are actually fairly bluntly tipped, is shoved up around the tendon till it meets the muscle itself, and the tendon itself is pulled right back in the opposite direction. As this is shoved in this way, the tendon is pulled back out. So that's an extraction. So that's an extraction of a tendon. Muscle, I could possibly imagine. We have extraction of bone marrow, for example, biopsies. Now there's an extraction of bone. So use your best discretion as to really what is fundamentally the root operation at hand, whether excision by cutting or extraction by pulling by force. And that is your option for extraction of musculoskeletal structures. Now I should not be remiss in mentioning there is extraction of respiratory tissue, GI, and lymphatics too. So in any case where any of that tissue is removed by pulling and not by cutting, extraction is your root operation to consider. To be completely transparent, I did want to refer you to this actually quite recent coding clinic that talks about that very tendon extraction for an ACL reconstruction in 2017, which refers us to excision of a right upper leg tendon open approach for the hamstring tendon harvest. Well, in fact, these are actually usually done through tiny little incision, centimeter or two, which is really percutaneous, And as I illustrated, if a tendon stripper in fact is used, it's really more an extraction. So be careful not to just automatically run home to this coding clinic and call it an excision. You really must understand what technique was used, whether in fact they really did open the patient up and cut out that tendon, or whether they used a tendon stripper and it's an extraction. This is probably my favorite fix in 2018 PCS for spinal fusions, and it fixes a glitch that I will say that would permit us to stumble into coding an interbody device for a posterior fusion. So all it does is deletes the posterior fusion with interbody device. And those of us familiar with spines know that the vertebral bodies are the site of the interbody device. So it's impossible to have an interbody fusion device in the posterior column. Having a look at spinal fusion, understanding the columns are critical to know what's being fused and which or both of the codes to choose. Here we see the vertebral body in a coronal section, so straight from above, the vertebral body. So an interbody device happens between vertebral bodies, that is here, not here. Anterior column, not the posterior column. And here is just such an interbody device packed with allograft and autograft. This case may be a PEEK, which is a type of plastic cage meant to encourage bony growth through and around it to fuse this body to this body. And the only thing that's done in the posterior column here is insertion of the instrumentation, which is part and parcel of the fusion itself. That's not an interbody device. So, woohoo! Glad to see they fixed that. Here's an interesting little side note about a device change or addition for joint replacements. We have now a device character or device value for the hip joint replacement with zirconium, oxidized zirconium on polyethylene synthetic substitute. You ever stop and wonder why they have these super specialized things like this substance right here? Well, this oxidized zirconium is a proprietary product, oxidium. And where does this all come from? It has to do with patents. Smith & Nephew asked for this code to be created so they can differentiate their oxidized zirconium implant from others. Will it pay differently or not? Who knows? Can they track it through the data from our hard-earned PCS codes? Yes, and for whatever value that is, now there's a code for that. So this is a case for you to just be quite vigilant about the implant. The surgeon may or may not say oxidized zirconium. They may simply give you a Smith & Nephew part number, and by looking at the implant sheet and Googling that, you will see a picture of the device and a description which will lead you to know what you're actually dealing with to choose the correct device value. In the anatomical regions general, a body part has been added for excision, specifically that root operation that has existed in other cases like extirpation. What we have now is an excision of the oral cavity and throat. Now, previously there was extirpation, for example, of the oral cavity, which would be maybe removing a foreign body from the mouth, but there was no excision. PCS forced us to go to the specific mouth structures like tongue, gingiva, buccal mucosa, tooth, etc., and pick the exact body part. However, in the case of a surgeon removing some unspecified tissue from the oral cavity, for example, for biopsy, we didn't have anywhere to go to. Now we do in the anatomical regions general. In this example, I used the diagnostic, which would be, of course, the biopsy. What we would have had previously would have been excision of the pharynx or oropharynx, and then all of the substructures of the oral cavity too, but nothing like just the oral cavity and throat. Now we have a lot of sort of little housekeeping changes in PCS, which I'll go over. They're not very exciting necessarily, and they're fairly obvious as you go through the tabular. It's hard to get tricked up by these, but they're kind of interesting to consider, I think, anyway. The genitalia is now termed the inguinal skin, so instead of genital skin, it's inguinal skin, and it simply swaps that term for this one. A body part renaming to match what was already in the index anyway, and I will tell you as a former clinician, already in 100% common use in the United States. Metacarpocarpal, which is just a tongue twister, unnecessarily complicated, is now what it ought to be, carpometacarpal. And metatarsotarsal is now tarsometatarsal. So now you'll see, just like you'll index it, you'll now see in the tabular the tarsometatarsal joint instead of metatarsal tarsal joint. Here we have an instance of some economy in body parts, and if there's one example of revising a code to save us coders headaches, I think this is the one. That is, the greater and lesser saphenous veins have been combined into just saphenous vein. So in this very code right here has been reused from right greater saphenous vein, cross out the greater, it's just right saphenous vein. Now there's a coding clinic that asks what happens if we were given just the laterality and the saphenous vein, and the answer was, in a nutshell, was you have to query for the lesser or greater. That was in 2014. So woo for us, we don't need to query for that anymore. I will tell you a dirty little secret. It is always the greater saphenous vein, but we can never assume that. And so this is a welcome relief to me. Here you see a percutaneous endoscopic harvest of a greater saphenous vein on the medial aspect of this patient's thigh. Of course, that approach is implicit in the code choices as well as open. You need to choose accordingly, but that's how that's harvested for a coronary artery bypass graft or other graft requiring use of that native vein right there. Another example of body part combining, as I say, is the greater and lesser omentum is now just called omentum. So for omental biopsy, you might have excision of the omentum, open approach, diagnostic. Doesn't require us to distinguish, but it's anatomy that you should know as a coder, I don't know, a coder doesn't at least slightly like anatomy in medicine, but the greater omentum extends from the greater curvature of the stomach, and that's really what you think of as really the omentum. Now here you see an example of this omentum right here. It's quite broad. It covers the intestines like an apron, has lymphatics in it, and a lot of immune behavior, and it has the ability to sort of sequester off abscesses and protect the other organs from being infected. The lesser omentum, conversely, occupies the lesser or upper acute curvature of the stomach right here. Less involved in biopsies and so forth, but it's there. And the omentum is termed by surgeons to be the watchdog of the abdomen, or the dog. And this omentum happens to belong to a dog, if you look carefully behind there too. And that's because it does tend to help protect abdominal structures from infection and inflammation. And in fact, it's used, for example, with stomach ulcer perforations. Oftentimes they'll stitch that up and they'll patch some omentum over that perforation to help it heal. It's pretty neat use of an otherwise obscure structure we kind of take for granted. In that same general vicinity, we have another body part combining the right and left diaphragm. I actually never found these too hard to distinguish. However, getting surgeons to designate them might be a little bit more tricky, so maybe they're showing us a little mercy. Simply, we have for all approaches and root operations just drainage of diaphragm in this instance, or maybe repair of diaphragm and so forth. And here is looking from below the right diaphragm, looking up at the patient's right on our left, patient's left hemidiaphragm on our right. And in this kind of interesting x-ray, we see the right hemidiaphragm elevated up, presumably because the right phrenic nerve, which innervates the diaphragm hemispheres, has been paralyzed, causing it not to be able to contract and pull down. So, I mean, there's still a very strong anatomical basis for the right and left diaphragms. We just now lose that in the PCS coding. The cranio-maxillofacial bones, right and left, become one bone now, at least in these instances, the occipital, sphenoid, maxillary, frontal, parietal, nasal, and zygoma. I guess that saves a little bit of ink, but really never bothered me too much. And these are structures that are often enumerated by their laterality, but this is what we have in 2008. So what was the excision of the right sphenoid bone, percutaneous endoscopic approach, is now just excision of sphenoid bone, percutaneous endoscopic approach. And you'll see the code, as is often the case with these, is just simply reused. They use the right to become the sphenoid bone, and the left was just thrown away and deleted. Here's an associated concept of that, which I will call a body part reallocation, where nothing was deleted. They just changed the concept from anterior and posterior neck subcutaneous fascia tissue to right and left. I cannot explain why, but all the codes for anterior, neck, subcutaneous, and fascia become right, and all those codes for the posterior become left. Now this does happen to match the laterality concept for other codes. So for the arm and leg, subcutaneous tissue, and fascia, it's right and left, so perhaps it's an attempt to match that. But anatomically, the distinction between anterior and posterior in the neck is more important. That's my clinician outlook on that, but nonetheless, somebody thought it was important enough to change it to right and left, and so that's what we have. Bear in mind, this is, again, subcutaneous and fascia, not the skin. So for neck skin, we still have this skin body part to choose from, and it's just neck skin, no laterality, no anterior, posterior. So the trend is to use right and left now instead of anterior and posterior, upper and lower. Not so fast. Slightly different body system from subcutaneous and fascia, the bursa and ligaments. Also a soft tissue, but obviously a different function for it. In many root operations now, there was a right and a left. Now, the codes previously used for the right become the upper spine and sternum, and the left codes were recycled to be the lower spine and ribs, for example, in the thoracic area. So what was an excision of the right trunk bursa and ligament, open approach, becomes now the excision of the upper spine bursa and ligaments. Now this actually kind of does make more sense, at least, than the neck, subcutaneous, and fascia thing, because the anterior ribs and sternum are different from the lower spine and rib attachments too. So I guess you could make a stronger case for that, but just be careful when you're coding this fairly obscure type of procedure if you happen to run across one. Speaking of ribs, the laterality has become number of ribs too. So there's obviously really no trend in renaming these things by the side or by the site or the anterior posterior. They just mixed it all up. The right rib PCS codes become 1 to 2 ribs, and the left rib PCS codes become 3+ ribs. Here's some examples. Excision of the right rib percutaneous endoscopic approach for biopsy, for example, might be excision of 1 to 2 ribs, percutaneous endoscopic approach, same exact code. And if it were done by biopsy, it would essentially only be the one rib anyway, so nothing really is gained specificity-wise. Or if that was an open biopsy, excision of the left rib, open approach, and they biopsied 3 of them, well, now that's the code we would use. Same code, turn from left to 3 or more. That sounds like a miserable procedure to have 3 open biopsies of 3 separate ribs, open approach. Ouch. There was one single change on the obstetrics section, and that applies to the body part of products of conception retained. Now, there's a body part of products of conception, which includes a baby, placenta, cord, a miscarriage, anything that resulted from the union of egg and sperm. That's the product of conception. It's very unromantic the way they describe this in PCS, but that's what products of conception are, and that is one body part, but the retained products of conception are ones that are left in after a normal process, for example. So a retained products of conception is not going to meet a baby. It may be placenta, a cord, or a miscarriage, something that's left in after the intended birth process or some other procedure too. So what we've done is added a qualifier for manual extraction of those retained products of conception, or products of conception, comma, retained. So not to be confused with the root operation E for delivery of products of conception of a baby, even if it's done manually. What is really meant by this is a very specific instance, and that's pulling the retained placenta and or retained cord with the hands manually, no instrumentation, no vacuum, no suction, after birth. So essentially, you may have a patient who's given birth and the placenta is left in, and the obstetrician or the midwife reaches in, pulls out the placenta. Here's what you have. So you have manual extraction of products of conception by natural or artificial opening, or it may be done endoscopic. In the home stretch, we have a few changes in the introduction section. Anesthetic in the eye. Okay, tiny little tweak. local is taken out. I guess any anesthetic in the eye by external approach is going to be a local anesthetic. I cannot imagine somehow having some general anesthetic to the eye placed by external approach. So you can scratch that local part out. In the new technologies section, we have some surgery type procedures too. An introduction of concentrated bone marrow aspirate into the muscle, percutaneous, for what that's worth. It would ordinarily be in the introduction section, but it's a new technology too, so it's got in its own section. And then reposition of the lumbar vertebra for scoliosis with magnetically controlled growth rods. I've seen this in real life too, and it's pretty new and it's pretty neat. And there is a new technology code for it, and that will presumably be placed in the upper and lower bones section later. We have some special new drugs in this, like the oxidized zirconium hip implant, presumably meant for tracking, and your facility may or may not require you to code these kind of things, but immunotherapy drugs like benzlotumumab, monoclonal antibody. Remember that all these drugs that end in MAB or monoclonal antibodies for immunotherapy. Introduction of this particular drug into a central vein percutaneous approach has its own new technologies code. Other body parts, so to speak, for this or substances for introduction in the new technology section. Engineered autologous chimeric antigen receptor T-cell immunotherapy. That's a mouthful. Look out for it. Endothelial damage inhibitor to a vein graft, if you encounter that. And cytarabine and daunorubicin, those are chemotherapy agents, not monoclonal antibodies, but nonetheless delivered in a special means by liposomes, so presumably concentrated in some tiny little particles of fat meant to be delivered more effectively to the tumors where they can affect their antineoplastic effects. I hope you've had a little bit of fun reviewing the 2018 ICD-10-PCS updates with me, Ed O'Byrne from Healthcare Resource Group. You're welcome to email me at the address you see there if you have any questions, comments, or feedback, and we will see you for the 2019 PCS updates, if not before. Take care.